Thank you for joining our webinar on the role of humidity in reducing airborne virus transmission. My name is Abby Rogers, and I will be facilitating this webinar. If you have any questions during the presentation, please submit them using the Questions tab in the control bar, and we will respond to them at the end of the presentation. I will now hand this off to Duncan, our DriSteem Global Business Development Leader.
Thank you, Abby. Today we are going to take a look at the role of humidity in the airborne transmission of viruses, and of course with particular reference to the current COVID-19 pandemic. If we think about today's situation with COVID, it's creating a heightened sense of awareness of the impact of airborne viruses, and in particular, as building professionals, a real need for us to consider how we address this from the point of view of the built environment. The severity and global impact of COVID-19 has seemed to catch the medical profession by surprise. However, within the field of humidification and HVAC engineering, there has been an ongoing debate as to the many benefits of healthy levels of indoor humidification, particularly with respect to reduced HAIs or hospital-acquired infections. This discussion has been increasingly supported by scientific research. Today, in light of this research, we will review the role of humidification to help reduce the transmission, infectivity, and severity of COVID-19, and briefly discuss some strategies for implementing this non-pharmaceutical intervention. Our goal will be to improve the understanding of the relationship between humidity and health and wellness, and touch on the current standards and how to have a short and mid-term response to the virus. I don't think I need to remind you that the healthcare market is a very significant one. It's currently valued at about $8.4 trillion. And in the US, for example, the HVAC portion of the healthcare market is estimated to be close to $3 billion annually. In addition to the challenges faced by hospitals, we also see the virus impacting the long-term care and nursing home markets. These are also facilities where we can expect increasing demands for building solutions to combat the virus. In the US, we have around 15,000 nursing homes, with about 70% of these in private ownership. In addition to combating the virus, the residents can benefit in other ways from healthy levels of indoor humidity. As an example, low humidity impacts the elderly. Issues like dry skin and bed sores can, in the case of diabetic patients, lead to severe infections, amputations, and even death. Why is it so critical for us to look at the role of humidification in the built environment? Healthy levels of humidification can help to reduce the spread of the virus, and in particular to protect staff, patients, and residents, many of whom are our most vulnerable population. In addition, there is a real impact in terms of costs. Although we're focusing on COVID-19, the spread of airborne viruses, it should be mentioned that humidification has a role to play in reducing hospital-acquired infections. These infections are the cause of significant economic costs to the hospital system, where these facilities must conform to the Joint Commission's healthcare standards. Why be concerned about humidity levels in the clinical setting? There are really three elements. Firstly, persistence and dispersion. Low ambient humidity reduces droplet size, which allows for a prolonged airborne period, which in turn allows for further travel distance. The low weight due to loss of water prevents the virus from being knocked down and then cleaned up with usual surface cleaning or hygiene techniques. Extended airborne time may be as much as 36 to 72 hours and allows for significant travel. In addition, low humidity and low droplet weight may allow viruses to become airborne after settling or resuspended. We should note that this is also true for HAI such as MRSA, C. diff, and so on. Secondly, infectivity. Infectivity is impacted by low ambient humidity. It's associated with reduced droplet size, which allows for deeper penetration into the lungs where there is a less effective biological response. This is aggravated by the low humidity conditions reducing the body's own immune response, i.e. inactivated or reduced functioning of cilia, reduced or thickening mucosa, and other biological responses. And finally, viral activity. Low ambient humidity levels act on the aerosol salt content, which allows for prolonged viral activity. Higher relative humidity levels render the virus inactive. In addition, higher humidity levels influence the patient's own cellular recovery. We should recognize that humidity plays a role in maintaining the patient's immune response and the ability for them, therefore, to fight off the disease. We'll take a look at all of these factors as we review some of the current clinical research. Numerous studies have tracked the behavior of airborne viruses, and now urgent interest is generating almost daily papers and articles. It is critical for us to understand, in light of the current research, how airborne viruses behave. Airborne viruses are expelled as aerosols through breathing, speaking, coughing, and sneezing. They may also be expelled during surgical procedures such as intubation. We've even seen examples recently of infections amongst socially distancing choirs on the west coast of the United States. It is believed that COVID-19 or SARS-CoV-2 behaves as an aerosol in similar ways to SARS or SARS-CoV-1, MERS, Middle Eastern Respiratory Syndrome, and H1N1 influenza, which have all been widely researched over the past 18 years. How long an aerosol remains airborne and how far it travels affects not only the spread of the infection, but the severity of infection, because respiratory viruses are most harmful when inhaled deep into the lungs. Aerosols that desiccate into virus nuclei due to low ambient humidity may be traveling distances and infect patients beyond the current 6-foot or 2-meter social distancing recommendations, and are demonstrated to be more infective in low humidity environments. Moving to the next slide, we can clearly see the potential for significant aerosol travel. I should mention that we have curated a number of studies which you'll be able to review at your own leisure. This presentation will be available to you, and these studies are hyperlinked here, as well as individually with comments at the back of the presentation. We'll take a look at a few of these in more detail. The first study that we want to touch on is the famous SterlingArundo study from 1986. They concluded that the optimum range for health, wellness, and comfort being between 40 and 60% relative humidity. This chart is probably very familiar to most of you, as it is frequently referenced by ASHRAE. You can see the bluish green band. This is the optimal range for reductions in the impact and infectivity and survival of viruses. It's important to note that this is also true for many bacteria, as well as a number of allergens. We see the positive impact of humidity in terms of human well-being, not only in terms of the impacts of viral infections. In 2012, YangMa from Virginia Tech postulated the relationship between virus, solutes, and water, and suggests virus viability in aerosols may be impacted by mid-range relative humidity. We have added links to some video and multimedia resources at the end of this presentation, and I would highly recommend viewing Lindsay Ma's YouTube hosted presentation. Also in 2012, NOTI worked with the CDC, or the Center for Disease Control, and NIOSH, the National Institute for Occupational Safety and Health, to research the airborne spread of influenza. It was concluded that improper mask type and mask fitting, such as for the N95, provided limited protection to small particle nuclei. This research was seminal, as we will see later that maintaining optimal humidity levels will help to reduce small droplet nuclei formation and resulting infections. Stephen Welty presented a paper to ASHRAE in 2013 based on his earlier research for the EPA and CDC in 2009 following the H1N1 flu pandemic. And yes, it was classified as a pandemic back then by the CDC. It deals extensively with the airborne spread of the virus and noted the influence of relative humidity levels, as well as the seasonality of influenza, heavily influenced by low indoor relative humidity. This work was backed up in 2018 in a real-world study by Jessica Ryman with the Mayo Clinic and DriSteem Corporation here in Minnesota. It was a side-by-side test of the impact of raised humidity levels to combat the flu in a classroom setting. Results clearly demonstrated that humidification can act as a non-pharmaceutical intervention for the flu. 2020, Dr. Nancy Goff from Johns Hopkins provided a layman's explanation of the 2019 study by Iwasaki. Low ambient humidity impairs barrier function and innate resistance against influenza infection. This is a very interesting study coming out of Yale. In this study, the researchers used genetically engineered mice with human-like lung tissue and were able to explore the impact of low humidity on both the infectivity of influenza virus as well as the recovery time for lung tissue. 40 to 60% humidity was clearly demonstrated to reduce infectivity while supporting physiological and immune response, and most importantly, cellular recovery. Beralba has been able to demonstrate pathogen-bearing droplets and aerosols can travel 25 feet or further, as shown in this capture of a sneeze and the related aerosol cloud. This is significant as the aerosol cloud will be immediately acted upon by the ambient conditions, and more specifically temperature and relative humidity. A lower ambient RH will reduce aerosol particle size and weight to create virus nuclei. Droplet sizes are generally below 20 microns and aerosols from 20 down to 10. Below 10 microns, we have droplet nuclei that may be as small as 0.5 microns. In a low ambient RH environment, the aerosol droplet may immediately shed moisture and reduce its size and weight to become a droplet nuclei. The droplet size impacts its float time, ability to travel, and its depth of penetration into the respiratory system. In this slide, we see an illustration of aerosol size versus float time and distance traveled. As lower ambient RH desiccates the aerosol, it may remain airborne for an extended period of time. Some studies have shown as much as 72 hours. From the perspective of built environment, we have to consider the capacity of our filtration systems to capture small particle size. We should recall with SARS that it was possible for aerosol viral particles to float not only along corridors, but also out of buildings and be pulled into the ventilation systems of adjacent buildings as much as 600 feet away. Very recently, researchers at the University of Helsinki in Finland have modeled the behavior of the COVID virus. In this particular example, they modeled the behavior of the virus in a supermarket setting. You can see that the simulated carrier on the bottom right-hand side has generated a particle cloud that is drifting not only through the aisle of the supermarket, but actually moving across the top of the shelving and potentially infecting somebody in the next aisle. They found that smaller particles, so 5 micrometers or microns or less, were able to travel significant distances. Many of you may have seen this on the news recently. Now, when we think about particle size, we've mentioned that humidity acts on the aerosol. So as the aerosol is expelled, in the space of about 1/2 to 1.5 seconds, we can see that aerosol particle desiccates and dries. And as it dries, it will shrink in size. In a higher ambient relative humidity environment, we will be able to see heavier particles settle quickly. That's demonstrated by the blue particles in the bottom right-hand side of the screenshot. Droplet size impacts on infectivity, longevity, and depth of penetration. We've looked at how humidity impacts the viral aerosol in terms of its float time and potential travel. But another aspect which is critical is its impact on the infectivity of the virus. This is a respiratory virus, and the virus in the form of droplet nuclei has the potential to penetrate deep into the respiratory tract, and in particular into the lower respiratory tract. This diagram illustrates the potential depth of penetration based on aerosol or droplet nuclei size influenced by ambient RH. This is significant as it can bypass the body's defense mechanisms. This increases the chance of infection and the severity of the infection. You'll see in the following graphic here that we can typically capture large particles between 10 to 30 microns in our nasal mucosa. We still see a capacity to fight the virus in the 10 to 20 micron size in the upper respiratory tract. The body's mucosal layer combined with cilia can clear these particles. It's important to note that low RH has been demonstrated to reduce the effectiveness of both mucosal production and cilia action. Smoking and vaping, for example, tend to neutralize the body's own natural defenses, which has given rise to greater mortality. The smaller droplet nuclei can move deeper into the lung and effectively into the alveoli, where we start to see a lack of capacity or capability for our body's immune system. That's particularly important since we also know that we have no natural antibodies or immunity. This is a novel or new coronavirus as it was transferred zoonotically from animals to humans. As such, we need to depend on other mechanisms within the body to allow us to address or attack that virus. Recall Iwasaki's experiments conducted at Yale that found that the body's immune system is best equipped to combat respiratory infections at 40 to 60% RH. In addition to improving the body's immune response, higher humidity levels were also demonstrated to improve cellular recovery. Notai also demonstrated that 40 to 60% RH reduces infectivity. If you look to the fourth chart D on the bottom right-hand corner, you can see a less than 1 micron fraction is most infective from 10 to 30% RH and least infective at 43% RH. Again, Iwasaki has demonstrated that an optimal humidity level inactivates the viral nuclei. Maintaining an optimal humidity level reduces the virus's viability in the environment. This can be both airborne as well as on a surface. And a number of studies have shown that between 40 to 60% RH provides that greatest level of inactivation, meaning that the virus is no longer a concern to us. In addition to considering physiology and the behavior of the virus, we also need to consider the potential seasonality. Alan Evangelista has recently published a paper, The Seasonal End of Coronavirus Hospital Admissions with the Implications for SARS-CoV-2. Whilst we need to be mindful that our focus has been on relative humidity in the built environment, environmental conditions such as higher absolute humidity may reduce cases and transmissions in the summer months, for example, in the Northern Hemisphere. However, since we are considering the built environment and indoor RH, we need to be cautious and not to let our guard down. And of course, we have an implication of a second wave, similar to that which occurred with the Spanish influenza pandemic. Hosseini has also noted the impact of ambient conditions and also supports the argument for seasonality and concerns for a second wave. And you'll notice at the top of the diagram that under cold and dry conditions, suspension time and viability is at its highest level. I mentioned that in addition to viral respiratory infections, healthy humidity levels can also play a role in other hospital and clinical care settings where we see nosocomial or hospital-acquired infections. These could be bacterial pneumonia, C. difficile, MRSA, medicine-resistant Staphylococcus aureus, and others. In all of these cases, the presence of these HAIs in the hospital puts a tremendous burden on the hospital in terms of the cost of care. The reason is that if you were admitted to the hospital, but you didn't have these pre-existing conditions, the hospital is effectively responsible for the cost of your treatment if you acquired these during your stay. That has a tremendous economic impact. So when we think about the cost of implementing and operating humidification equipment, we really should be cognizant that it has a tremendous ROI or payback in the sense that we're going to be able to avoid a lot of unnecessary costs associated with hospital-acquired infections. I hope we have sufficiently discussed the science behind airborne viral transmission and the impact of indoor air hydration, another way to look at humidity levels. Let's talk a little bit about ASHRAE and humidity level guidelines. Currently, ASHRAE's guidelines for hospitals vary from 20 to 60% RH, dependent on the usage of the space. From an ASHRAE perspective, some of the areas that see higher levels of RH are the intensive care unit, or ICU, from 30 to 60%, and burns units from 40 to 60%. As a volunteer firefighter, I'm quite interested on the impacts of humidity on burns. It really is very simple. If we're looking at drying out skin cells, we're looking at those cells dying. So looking at optimal conditions or highest humidity levels being utilized in those burns units, along with elevated temperatures to maintain patient core temperature. Globally, it should be noted that Japan has for some time recognized the importance of higher RH levels, despite the fact that they are an energy poor country and are willing to hold patient safety and well-being ahead of energy savings. We should recall that even though the Joint Commission requires maintenance of ASHRAE levels, there is no prescriptive requirement to monitor or report. We would argue that a stable and regulated environment should be monitored and maintained, just as it would be for quality requirements in manufacturing. To highlight the potential of substandard levels, a letter provided by 3 anesthesiologists regarding indoor conditions was published in the British Medical Journal. These were Boston area hospitals. Since as human beings we're not sensible to humidity, there is a real possibility that non-compliant conditions may not be obvious to occupants or building operators. ASHRAE has recently created the Epidemic Task Force and have made resources available on the hyperlink provided. This has included a special statement that the transmission of SARS-CoV-2, which is the cause of COVID-19, the actual disease, through the air is sufficiently likely, that airborne exposure to the virus should be controlled, and that changes to building operations, including the operation of heating, ventilating, and air conditioning systems, can reduce airborne exposures. So, optimizing humidification levels will be one of the means of combating the virus. We'll talk a little bit about some steps that you can take in a few minutes, but you should be aware of the recent position document on infectious aerosol transmission. A link has been provided. This position paper recognizes the role of the built environment in reducing the transmission and impact of the virus, and more importantly, has extended this to commercial buildings that currently lack minimum relative humidity guidelines. ASHRAE notes in the document the contribution of the HVA system to help control the spread of the virus by interrupting the transmission route. Recognition of the role of relative humidity in the biological response, citing some of the studies we have already reviewed. Maintaining temperature and humidity as applicable to the aerosol of concern, and we would argue that 45% would be the optimum level. And as mention of significance is the inclusion of commercial or non-healthcare buildings into the guidelines, something to consider as we begin to repopulate or reoccupy these facilities. I think to emphasize things, we can look to the recent statement from the White House, a clear recognition of the survival of the virus as an aerosol for greater than 60 minutes at low RH of 20%, as mentioned by the Department of Homeland Security. They have for many years focused their attention on the potential for bioterrorism, such as the post-9/11 anthrax infections, as well as pandemics such as Ebola, and they're therefore a highly credible authority. If we continue to look at building industry best practices, CIBSE, the Chartered Institute for Building Service Engineers in the UK, have cited Lindsay Ma's work and indicated that airborne transmission may be a route of infection. They indicated it is prudent to ensure ventilation is operating appropriately to protect occupants, and we would argue that ensuring healthy relative humidity should be a key part of this plan. CIBSE have just released their guidance for ventilation systems. Humidity levels to be maintained above 40% where possible. No upper limit is mentioned, but we would suggest a maximum of 60% RH. REVA acknowledges the growing evidence for airborne transmission and that humidity acts upon droplets to evaporate or desiccate these. However, regrettably, they have not made a statement regarding maintaining what we consider optimal humidity levels. However, a Eurovent have indicated that humidity levels should be kept at greater than 30%. The suggestions made after the H1N1 pandemic to the CDC and then ASHRAE and see Welty's CIAQ document mentioned earlier are likely relevant to COVID, mainly a holistic approach to mitigation of the virus in a phased or stepped approach where increased humidity levels form the backbone of a strategy that includes increased air changes, effective UV, either in duct or in room, improved bathroom exhaust, and finally, effective filtration and greater than MERV 13. Keeping indoor humidity levels at 40% to 60% relative humidity is a safe, easy, and efficient way to reduce the spread of the virus. Not only viruses that cause COVID-19, but also, of course, other respiratory illnesses. It will not only protect the occupant's health, but as we've mentioned, may help to reduce the severity of the infection and the length of time that's therefore required for hospitalization. Humidification systems can be quickly installed on a wall and adding moisture to rooms right away if they're using a blower or direct system. Larger humidification systems can often be incorporated into a facility's existing HVAC system, such as in duct in the air handling unit or with a rooftop unit where space is a premium. We would recommend that any strategy starts with a site survey. Most US healthcare facilities were commissioned with humidification. This equipment may not be operating due to maintenance issues, may sadly have been turned off, or the humidification levels reduced. And we've seen examples in the letter of the 3 Boston area anesthesiologists. Taking RH readings using a hygrometer or checking the levels via the building management system in areas that may experience COVID cases or areas where asymptomatic cases may present will quickly determine if a facility is optimizing their defense against COVID virus. A target of 45% RH is generally recognized as providing positive benefits. If you're seeing lower RH levels, then test the equipment to see if it's operating correctly, adjust or raise set points if required, and of course, work with local sales agents to explore options for additional capacity or output. If you're looking at getting there quickly, commercial-grade humidification equipment provides the control you need to maintain that optimal humidity level. Simple access to power, water, and drain is all you need to get a system operational. And in fact, in hospital environments, think of any place where there is a sink. Very common also, of course, in nursing homes. And of course, we also see a lot of decentralized systems requiring local systems. Reps can help determine appropriate size and type of equipment in as little as a day. With DriSteam's local US manufacturing and expedite capacity, a solution can be rapidly implemented. Equipment can be ordered and on-site in just a few weeks, sometimes faster, and installed in a day or so. And of course, you can count on a system from DriSteam to provide superior performance, protecting your staff and patients and your investment. I'd like to close with a quote from Justice Archie Campbell, who led a royal commission into Canada's SARS epidemic, and is referenced here in an excellent article by Harriman and Bruchot. The point is not who is right and who is wrong about airborne transmission, nor is it how far large droplets travel. The point is not science, but safety. Scientific knowledge changes constantly. Yesterday's scientific dogma is today's discarded fable. When it comes to worker safety in hospitals, we should not be driven by the scientific dogma of yesterday or even by the scientific dogma of today. We should be driven by the precautionary principle that reasonable steps to reduce risk should not await scientific certainty. And I think here we can substitute engineer or building operator in place of scientist. Humidification is common sense science. When it comes to protecting staff, patients, and residents, you can make the change immediately and easily. For more information, you can follow the hyperlinks to resources available on our website. We have specific COVID-related resources under our healthcare section. We also have a free white paper that's available to download in addition to the presentation today. DriSteam sales team will continue to host additional technically focused webinars, and most importantly, you have the expert knowledge available by contacting your local DriSteam representative at the Find a Rep link. As mentioned, you'll see at the end of the presentation, we've placed a number of resources for you that are also available through our website. I'd like to thank everybody for their time, and I believe that we're ready for any questions that you may have. I'd also ask that you consider following DriSteam through our LinkedIn company pages. And with that, Abby, I'll open up for questions.
Sure, Duncan, we do have one question. How does the DriSteam option compare to the steam injection from the boiler plant?
A very good question, and actually a fairly critical one. There's some pretty good research, and in fact, dates back some time as to the potential downside of utilizing direct injection or steam directly injected into the duct or into the air handling unit. The reason for this is that boiler steam may be dangerous to human occupants. We have a number of chemicals that may be present in boiler steam, for example, amines and other chemical compounds that may be used to avoid scaling. For this reason, if you'd like to use boiler steam as an energy source, we would recommend a steam-to-steam unit. Steam-to-steam basically will take the energy or the steam available from your boiler plant, pass it through a DriSteam humidifier using a clean water or potable water tank, and then we'll be creating clean steam. There is actually a recent case study that's available on our website from Mercy Hospital in Buffalo, New York, which included steam-to-steam. Of course, I should mention that DriSteam has the ability to provide solutions using a wide range of humidification technologies and energy sources. In addition to adiabatic on the isothermal side, we can look at electricity, direct injection, steam to steam, as well as gas. And currently, gas is a very attractive option because of the relatively low cost and the quite high capacity. Since our new GTS steam series gas-based unit is an extremely high efficiency. It's a fully condensing unit with greater than 95% efficiency, and it has a low NOx, low emission. It's therefore a very friendly or environmentally friendly solution should you have the space to incorporate it. Of course, I'd mentioned that if space is a challenge, there is the possibility for outdoor units as well. Do we have any more questions, Abby?
We do have a couple more. Has the effect of RH levels been studied for other non-viral infections like bacterial Legionella?
So in terms of bacteria, we referenced the Sterling chart. There are a number of studies available, and I would be happy to send those to the participants or individually to the person asking the question. It's interesting that there are some viruses as well as bacteria that, of course, thrive in high environments. And again, if we reference the Arundel slide, you'll see that when we get above 60%, we have concerns. And certainly, those are both humidity as well as temperature based. I'm very curious personally to see the results of COVID testing and lab research in extremely high humidity environments and higher temperature. You'll recall again the slide from Hosseini showing the three different, I guess, combinations of temperature and humidity. MERS, for example, because it is a respiratory infection, is quite interesting. It's believed that whilst it is very virulent in low humidity areas, the higher temperatures common in the Middle East have kept its spread to a minimum. And again, if we look at current spread of infection that's occurring, for example, in Brazil, this would seem to indicate that this is a result of the virus doing well at very high levels of humidity or ambient or relative humidity. And there is some research that indicates that. Of course, we should be cautious that we're talking about the relative humidity and generally within the built environment. So what are we experiencing within the building envelope? And here, again, it's critical that we understand what our RH levels are. Most of us are generally unaware of the actual RH levels. As I mentioned, we're not sensible to that. So we need a simple hygrometer to verify.
Duncan, do you recommend inhaling warm steam from boiling water as an intervention in curing COVID-19?
Well, I'm not so sure inhaling boiling water. I mean, we have to be careful we don't cause damage. I can think of somebody recently suggesting that we inject ourselves with disinfectant. As long as we're not actually damaging our lungs, moistened air, and of course we should be aware that humidity can be either warm or cold. I didn't really touch on that cold element regarding Legionella, but generally speaking, warm steam, meaning clean steam from evaporation, or due to boiling, I should say, would be preferred because it's guaranteed to be hygienic with no carryover of any form of compound. So yes, I would suggest simply trying to raise the levels. It will help cellular recovery. It's not going to be a direct preventative by inhaling it, rather the environment that you're in will benefit from maintaining that 45% or so RH.
And that is all the questions we have, Duncan.
Great, well, appreciate everybody's time. Again, the presentations will be available for you to download. Please feel free to share these. And certainly feel free to contact us should you have any further questions. Appreciate your time and have a wonderful afternoon.